Washington University School of Medicine in St. Louis is playing a big role in the Human Tumor Atlas Network, funded by the National Institutes of Health. The project is using advanced technologies to study and map individual cells. The main focus is breast and pancreatic cancers, but understanding deadly brain tumors is also on their radar as part of a Human Tumor Atlas pilot project. A $9 million grant is dedicated to the 3D mapping of tumors for both breast and pancreatic cancers so that doctors can more effectively kill the cancer cells. But principal investigator Li Ding at Washington University School of Medicine in St. Louis is working on the launch of a new pilot study to map the progression of an aggressive brain tumor. Researchers say glioblastoma is the most common malignant brain tumor and kills about half of patients within 14 months of diagnosis because of the lack of effective therapies.
We also have a very strong interest in understanding glioblastoma, GBM, which is one of the most deadly cancer. We are proposing a pilot project within the Human Tumor Atlas to focus on GBM.
The Human Tumor Atlas Network is an effort to understand the lifespan of tumors, so researchers are creating 3D maps of tumors and their surrounding microenvironment, analyzing how the maps change over time. Ding uses detailed genomic analysis to characterize the cells through single-cell sequencing. This allows them to identify which portion of the tumor may survive initial therapy and continue to grow despite aggressive treatments. And single-cell sequencing of the microenvironment tells scientists how the patient's immune system is responding to the tumor invasion.
For this pilot project, we will be using the imaging-guided approach to do the sampling of multiple regions of the brain tumor. Then we are going to analyze each region. This imaging-guided approach will allow us to precisely map out the position of the tumor and allows us to know which part of the brain tumor are most deadly.
Ding says this is promising as researchers here are already making strides to better understand glioblastoma, which is diagnosed nearly twice as often in males compared with females.
Why is it more likely that a male will develop glioblastoma? Why is it more likely that they'll respond less well to therapy? Because in understanding that, it would be our hope that we would develop some insight into how to tailor treatments and improve outcomes for everybody.
Professor of Pediatrics and of Neuroscience, Joshua Rubin, identified distinct molecular signatures of glioblastoma in men and women that help explain why more males get glioblastoma and die from the disease than women.
We found that survival in male and female patients seemed to be driven by very different molecular pathways. In the males, it was all about regulating cell division, and in the females, it seemed to be about regulating invasiveness.
The findings suggest that tailoring treatments to men and women with glioblastoma based on the molecular subtypes of their tumors may improve survival for all patients.
For me, among the most exciting things about this study is the way that it might impact on clinical care. Our hope is that these findings will change the way that doctors think about treating glioblastoma and other cancers in a male-specific and a female-specific way. It's our expectation that doing that would improve outcomes for everybody.
Which is also the hope for being included in the Human Tumor Atlas Network. Ding says studying disease progression in this way will help develop better treatment options for future cancer patients with similar cancer cells and similar microenvironments. For HEC, I'm Kathleen Berger.